Right? 3, 2, 1, and we are ready. We are ready to get another exciting interactive session. Today's session is a mixed session. First and foremost, I always cherish going live on Facebook and reaching a larger audience compared to the Instagram live which I was doing this August. And now we have a set of enrolled participants, special test and differential diagnosis. So they are attending this package, more than 75 participants. Okay, they are attending it. Most of them were the previous members who actually completed the free manual therapy course. They were also eligible for this package also, free. And once the offer has ended, then there were others who were joining in from the members at the discounted fee. And then later we also have non-members who enrolled for the same special test and differential diagnosis, where their fee includes the lifetime membership. Okay, so it's been a big get together of all of us, and although the topics have been divided into regions, so we had cervical, spine, scapula, then shoulder, elbow, wrist and hand, okay, regions. My purpose of coming today live is mainly the region to region. Okay, there are some disorders which are multi-regional. Okay, that means there are some conditions which involve neck, shoulder, elbow, hand, okay, all together. That is first, multi-regional. And the second thing, regional interdependence. Okay, there is a problem or dysfunction in one region where the symptom is felt in the other region. Okay, or primary dysfunction in one, maybe the scapula, adds on to a secondary dysfunction in the shoulder, and symptom may be in the elbow. Okay, for example, a protracted scapula with internally rotated humerus creating a lateral epicondylalgia. Okay, so there are a lot of aspects to see pathomechanics. So I thought, okay, let's go live and get the inputs. And also separately this interactive session also, everyone should be benefited by getting a certificate. Okay, so for those who have registered for this session separately, will be getting the certificate that they attended this interactive session. It's not a 1 hour session, it's a lengthier one. I've kept it for 1.5 hours, so that there is ample time for discussion right from either individual regions in the upper quadrant. Okay, I was telling you all the regions, or it's a multi-regional disorder, okay, which is either a musculoskeletal disorder maximally, and also of course the regional interdependence related to physical examination, because we are talking about special test and differential diagnosis. Okay, so your focus should be more on this and how these test findings or the differential diagnosis could actually help us in evolving a better treatment plan. Okay, so that's where we are going to be the prime objective of this session for the next 90 minutes. So welcome all the participants who are joining in slowly. Okay, and you can start putting your queries as comments so that we begin every moment more in terms of the fruitfulness of this moment that we share. Okay, as you are listening to me and also I am interacting with you. Okay, especially August has been a great month for AOMPT. Okay, so always every year the August will be filled with all offers. So this time we have so many free lifetime memberships also, because they completed the manual therapy course on time, the concepts course. Okay, so they got the free membership also. So it's all a bumper offer, all this for everyone. Those who are already enrolled in the special test and differential diagnosis have got e-training videos. Okay, so they got the videos free of cost actually. Usually the videos are extra fee, so they got it as a substitute instead of the live demonstration. Okay, so they will be more happy to learn it at their own convenience. Okay, they would have watched it, and it's actually what to say, you can watch it any number of times. Okay, even if first time you skip something, then you can watch it again. Okay, it's a lifetime resource. And especially physical examination, I want it to reach everyone. Okay, so that's where we are going to differentiate ourselves as a professional compared to a technician. Okay, so if you don't examine, then you are a technician. Okay, and if you don't differentially diagnose, you are not a clinician. Okay, so even the orthopedician understands these terms. So when you want to communicate interprofessionally, you want to tell them about the patient's clinical presentation, always a differential diagnosis will show you at a higher place. Okay, for them to recognize your decision making. Okay, so that's another important fact. And we should know which are the ones which are closely linked pathomechanically. Okay, we can't go around with all the diagnoses in the shoulder will not be a differential diagnosis. Okay, they are only different diagnoses. Differential diagnosis means it is related anatomically or pathomechanically. Okay. The first question we got from Dr. Ritu, madam is asking about narrowing of intervertebral disc in cervical spine. Okay. But she's asking about a question for treatment. Okay, again I know the focus. Okay, it's very difficult for us to target on the topic. Okay, many of us are out of focus. Okay, so it happens. Remember, the description itself says that it's a MRI report. Okay, or it is a X-ray report. This is not of a patient. Okay, so I am not going to treat an X-ray or an MRI. Okay, I want the findings of the patient, so that we diagnose and then we plan. Okay, so it's not going to be like jumping into conclusion, just there is a narrowing, so you decide as it's a cervical spondylosis, okay, degenerative disc disease, and then you start giving options like traction, okay, or spinal mobilizations and all that. Okay, whether it is necessary for the patient or not, whether the patient is presenting with stiffness, whether the patient has relief of symptoms with manual traction, okay, whether the patient has pain on flexion, okay, in the end range, flexion compression is more painful. Okay, these are all pathomechanics which will actually delineate that it is disc degenerative disease. Okay, and whether the symptom is there in the midline or interscapular region associated with a headache. Okay, it might be because of big pillows, okay, huge pillows, 2-3 pillows, and then you are lying down. Okay, so it may be a flexion posture adopted during work or your recreational habits. So all this have to be correlated from the history to the examination. Okay, and then see whether the patient's symptom presentation is linked, okay, to these examination findings. You can't go by an X-ray or a MRI. Okay, it's an unfortunate thing that we ask. There is narrowing of disc, so what to do? Okay, no, I don't do anything at all in that. Okay, I might have a narrowing of disc. Okay, everybody will have. If we drink less water, if our sedentary lifestyle, all of our discs will be smaller. It will be half the size of how the normal disc has to be. Okay, so you don't need a treatment for everything. Okay, so don't be like what is called as monkeys with bananas. Okay, so anything and everything you keep doing just to get the banana. Okay, so it should not be like that. Okay, so make sure that you should be focused. Okay, try to see what are the findings. If a patient, we are talking about pathomechanics in terms of either posture or movements. Okay, these two are the things which are mechanical. Okay, mechanical neck pain, when we say. Most of the disorders of cervical spine are grouped under either flexion disorders or extension disorders. Extension disorders are radiculopathy, facet joint syndrome, Okay, spinal instability, the ligament strain and sprains and instabilities. All these are extension disorders. Whereas flexion disorders are disc and muscle problems, okay, posterior muscles, trigger points, and the capsule of the facet joint strains, okay. All this will create a flexion issue. Stenosis is an extension, okay, and so a lot of things. If it's osteoporosis or there is wedge compression, it's a flexion disorder because symptom is reproduced in flexion, okay. So you should categorize whether it is unilateral, means whether it's a lateral flexion which is abnormal or it's a rotation which is abnormal. Along the lines of Shirley-Sarman, okay, the movement system impairment syndromes, that will be a more better pathomechanical decision making algorithm. How can we differentiate headache and cervical headache? The word itself tells, okay, when you are putting the words, one is headache, another is cervical headache. Know that headache that is caused from cervical spine is cervical headache. Okay, headache that is unrelated to the cervical spine is only headache. Okay, cervical headache or cervicogenic headache is a type of headache only. Okay, you don't have to differentiate. It is like you are differentiating between a mango and a fruit. Okay, mango is just one type of the fruit. Okay, so same like that. Basically, you have to rule out whether headache is from cervical spine or not. Okay, you have got a very beautiful description in the video for cervicogenic headache. Okay, checking the movements of upper cervical spine and also lower cervical spine, palpation of the muscles of the neck, which reproduces the headache. So it means that it's a cervical or cervicogenic headache. You are doing everything to the neck, nothing is reproducing the headache. Okay, you are doing all the movements in combinations and nothing is reproducing the headache. It is not a cervicogenic headache. Okay, cervicogenic headache is usually mechanical. That is also described in the video. It was very elaborately described. I don't think there is any confusion if you have really watched the video. Okay, I think you missed it. Okay, and it's very easy that already I have described about how to diagnose. Okay, you are going to examine the cervical spine, and if the headache is getting reproduced, you have diagnosed. Okay, and treatment is also, you treat the cervical spine, the headache will be relieved. Okay, that is the basic diagnostic criteria for cervicogenic headache. Why we can't accept that something can be simple? Okay, so that's where the thing goes. Okay, you find a restriction in facet joint, you palpate that, you get a headache, that means you have got the cervicogenic headache already. You have got a muscle which is tight, you got a trigger point and you are palpating and you are getting headache, it's a cervicogenic headache which is myofascial. Okay, why you can't accept this? Okay, I don't understand this. Okay, why do we get confused? Okay, what is making people to get confused? Okay, especially when the descriptions and demonstrations and video have been very, very direct and explicit. Okay, and more than individual diagnosis, you should concerned be about the regional interdependence. You should be more concerned about the multi-regional disorders. Okay, for example, cervicogenic headache is a multi-regional. One is head, other is neck. Okay, you have neck pain, you have headache, which is usually present only one side, preferably the same side. You won't have left side neck pain with right side headache. Okay, you can't diagnose it as cervicogenic headache. So these are all elementary things, okay, which is all there. If this side neck is causing the headache, it has to be same side. Okay, otherwise why it will be opposite side. Okay, and headache which is mechanical, that means with neck movements and neck activities, if the headache is getting reproduced, ultimately you know that the cause is cervical spine. Okay, you don't find a headache which is cranial causes as mechanical. Okay, so we had only two questions so far, Dr. Ritu and Dr. Shafiqul. Includes even scapula, shoulder, elbow, wrist and hand, okay, all regions. So don't be thinking about only particular regions. Okay, there are multiple regional conditions in musculoskeletal disorders. A simple example of cervical radiculopathy, where the symptoms come till the hand. Okay, so the symptoms travel all the regions, but the cause is cervical spine. But you might have a trigger point in any of the muscles in the path. Okay, and those who are not the participants, okay, not the registered participants, God save you, okay, because you have not seen the videos of the physical examination and differential diagnosis. So you will be nowhere. Okay, you will just have to search YouTube, search Google, do your hard work, and hit your head, unfortunately, if you have not yet joined AOMPT. Okay, so what I would try to say is develop a clear concept. Okay, like cervical radiculopathy is there might be a cervicobrachial pain syndrome, okay, where neck and arm pain is there, or it could be a thoracic outlet syndrome, which again causes till the hand the symptoms. And you have what is called as even myofascial pain syndromes and facet joint syndromes refer pain till the elbow. Okay, so you have symptoms coming in different regions. In shoulder, for example, even frozen shoulder will cause symptoms even till forearm. Okay, the referred pain. And elbow, very rare that it refers when too much of a distance, it won't create any problems, but hand it creates. Okay, especially like reflex sympathetic dystrophy or shoulder hand syndromes will create whole upper limb to be affected with symptoms. Okay, any kind of entrapment neuropathy at any area, definitely it's going to cause more in terms of multi-regional symptoms. Okay, because nerves have that potential. Okay, it's like there are basic things which simplify things. Okay, AOMPT was conducting manual therapy webinars, so many packages. Okay, 1, 2, 3. Manual therapy for frozen shoulder was a different topic. Manual therapy for impingement syndrome was a different topic. Okay, so everywhere the situation is the same. Okay, the in-depth focus and then application of manual therapy. So you have to get access, okay, if you want to get a clear picture. Otherwise, you just put it, you will find various answers from different people. Basically, you should understand that range of motion restriction is not there in impingement syndrome. Okay, frozen shoulder has a range of motion restriction. That's why it's called as frozen. Okay, so basically this is the simplest ABCD of LKG of differential diagnosis between frozen shoulder and impingement syndrome. Okay, the second thing is impingement syndrome having a painful arc. Okay, painful arc right in the middle or in the end. That's it, done, man, your diagnosis. What is the big deal in thinking that I get confused? Okay, because you are focusing on the confusion rather than on the clarity. Okay, so if your mind is clear, all that is clear will be visible to you. Okay, if you are confused, everything that is a mess only will be visible to you. Okay, so remember this is the basic difference between these two conditions. So don't think that patient will have only frozen shoulder. They can have an impingement in the end range. Okay, so we know that impingement syndromes can come in the end range secondary to acromioclavicular or sternoclavicular, okay, dysfunctions. So that can happen in frozen shoulder, whereas the painful arc in between, the mid-range painful arc, cannot come in a frozen shoulder. Okay, so all this, and you know the etiology. Impingement syndrome is an overuse injury. Frozen shoulder there is no overuse. It's only a metabolic cause because of diabetes or immobilization. Okay, all this kind of different causes that is. So when you see the picture, you will know that both are totally different. Okay, and special test wise, frozen shoulder has its own very less special test compared to the impingement syndrome, where impingement syndrome there is a test for bursa, there is a test for tendinitis, there is test for AC joint. Okay, there is test for longida biceps. Okay, every structure can be checked in impingement syndrome. Gross impingements can be checked, like coracoid, okay, impingements, or the subacromial impingements using Neer and Hawkins. Okay, various tests for impingement. Differentiating between a primary impingement versus secondary impingement, where primary impingement is tendinitis, so you have to check the muscles. Okay, so these are all elementary, okay, of differential diagnosis between these two conditions. Remember, whenever you want to assess a yellow flags, okay, you are trying to screen for psychosocial factors, you don't need a questionnaire actually. Because do you think that such patients who have psychosocial maladaptive behaviors will sit and answer your questionnaire? Okay, so just explore from your history. Okay, don't be too much into research. Okay, people develop questionnaires, I don't know how they validated and all those things. Okay, even a quality of life, for example. Okay, functional improvement, which activities, how much it is difficult, we can get a better recording. You think yourself. Okay, otherwise if somebody asks me, are you depressed? Okay, and you have an option that not at all, somewhat depressed, okay, don't know, or neutral, and then not depressed, or whatever it is, what to say, mildly depressed, moderately depressed, severely depressed, like that. So in this scenario, what will I mark? Okay, even if I am severely depressed, will I mark that? Okay, so why are you going for questionnaire? Okay, you should just find out from communication with the patient itself that they have a relationship with the emotions, their own understanding about the disorder is maladaptive. Okay, they are having the fear of movement, they are over expressive, exaggerating the symptoms, all these are yellow flags. Okay, so why go for questionnaires? Okay, questionnaires are usually used in Canada and US where there is a long waiting time. Okay, even in UK, for example, because patients come in outpatient practice, 50 patients will be waiting. Okay, you have to treat 5 patients, you can treat, other 45 will be sitting. So give them questionnaires, give them a self-evaluation form. Okay, so they will be sitting and just filling, and they are also educated. Okay, so they can, they can keep their mind occupied by filling those questionnaires, and especially it's for insurance company to pay them. Okay, so they have the protocol and the guidelines. In every patient you should do this questionnaire. For example, hospital anxiety and depression scale, okay, or Tampa scale for kinesiophobia, okay, fear avoidance beliefs questionnaire, that has a work subscale, and then it has a physical activity subscale. So you have a physical activity subscale where the score is 23, you can think of yellow flags, but that's only for research. Okay, it is not going to be in reality. Okay, and for us, it does not depend upon the score, it depends upon how much the interaction with the symptoms are. Okay, even a patient who is telling that I want massage and they don't do exercises, you should definitely think that they have a maladaptive understanding about the problem, because they will not cooperate, and they will be having any kind of active exercises or movements you are prescribing, means they will tell my pain is worsening. Okay, because they want passive treatments. Okay, so these all are indications in daily practice where you have to explore into what is their actual understanding. There's something called as motivational interviewing. Okay, that they should feel that we are interested in actually knowing their side of the story. Okay, and then in that you ask questions. Okay, you think that somebody has cursed you. Okay, you think that God is helping. Okay, God is punishing you for your old sins. Okay, these all kind of things will come. Then you tell. Okay, it is like, how did you get the things? Some achievements will also be there in the life. Okay, you tell them. Is it because of the curse that you got achievements? Make them realize that is it negativity alone it is going to be around them. Okay, they also have positive things which they are not focusing. Okay, so you just ask a question like a doubt. Okay, not like an expert who is going to solve their problems, but as a human being who can actually listen and share their problems. Okay, share their experiences. So in that way you should have to interact. We physical therapists live about physicians. We don't spend any time with the patient. Okay, we think the lesser the time we spend with the patient, we are a super expert. Okay, and in that bargain we are fooling ourselves. Okay, so that's the fact actually. Whenever you have this was a question from Dr. Harinath. He is asking about how to differentiate tear versus tendinitis. Okay, remember, tear is an acute injury, it's a massive injury. tendinitis is a overuse injury, it's chronic. So you have onset itself. If a person is totally normal and playing sports and after that getting a sharp pain, okay, and having difficulty in moving the arm, especially lowering the arm, okay, you might feel of a rotator cuff tear. But if the same thing is happening in a middle-aged individual, okay, who is maybe a diabetic or just obese, recreational badminton player, okay, used to have shoulder pain every time after the game, used to go off, and today he comes to you with more difficulty and more symptoms in the shoulder. Okay, so it's a gradual progression. Then you think of rotator cuff tendinitis. In rotator cuff tendinitis, resisted contractions will show, specifically testing the muscles. One major identification, okay, for the tendinitis is resisted contractions with palpation, because all the tendons in shoulder palpable, elbow, wrist palpable, neck totally palpable. Okay, so if you don't use palpation with the resisted contraction, you can't isolate the tendon. Okay, and isometric contraction will be very painful in a tear. Okay, but in tendinitis it will be only mild painful. Okay, so you can differentiate that. Also, the contraction itself may not be possible if the tear is a massive tear beyond 50%. Okay, muscle will be weak, and drop arm sign. Okay, all this will show there is a tear. Of course, diagnostic ultrasound will directly confirm the tear. To confirm, MRI will confirm the tear compared to the tendinitis, where there is a fluid collection within the tendon. Okay, so physical examination you can diagnose, okay, from the history also, from testing also, and absolutely, but your level of management for a tear will be much limited, okay, except in geriatric population where they don't get operated. Okay, if it's a young adult, you would prefer to get them the repair or the reconstruction for the tear, and then you rehabilitate them. Okay, so that should be the plan. Don't delay. One moment you found a tear, rotator cuff tear for example, better arthroscopic shoulder surgeon, okay, would be the best to handle this case. Okay, don't think that conservatively will keep and the tear will heal. Okay, no. That's not the logic of clinical practice. Okay. As I was, I think in one of the clips in cervical spine differential diagnosis, cervicogenic vertigo. Okay, so I was talking about differential types of vertigo. The vertebrobasilar insufficiency, which is vertebrobasilar vertigo. Other one is the visual vertigo. Okay, then vestibular vertigo, which is called as the BPPV, benign paroxysmal positional vertigo. Vestibular vertigo can also be central vertigo or vestibular neuritis, okay, peripheral only but more constant, it's not benign, and cervical vertigo. Okay, so everything is there. There's a lot of vertigo which is there. Okay, it might be because of, even vertigo can come because of medications. Vertigo can come because of what is called as age-related somatosensory dysfunctions. Okay, will lead to vertigo. Otherwise, the hypovolemia, hypotension, okay, all these are associated with what is called as the giddiness, will be perceived as vertigo depending upon the sensitivity of our somatosensory, vestibular and the visual system. Okay, so remember that when you are diagnosing, you should be very clear to differentiate, because the plan of management for each type of vertigo will vary. And also the extent of the dysfunction, because someone who's having a visual vertigo is like a motion sickness. Okay, they close the eye, there is no vertigo. Okay, when the eye is open, excessive vertigo. If they travel, they get vertigo. Okay, so all these things happens. Other ones compared to BPPV, where one side they lie down and they get vertigo. Okay, so or extension rotation in the one side. Same extension rotation could be vertebrobasilar insufficiency. The difference between BPPV and VBI, the vertebrobasilar insufficiency, is the nystagmus. Okay, horizontal nystagmus comes in vertebrobasilar insufficiency. Upbeating torsional nystagmus comes in the BPPV. Of course, BPPV is fatigable, it's benign, so it goes itself. Okay, but the VBI, it will worsen. Okay, if you are don't maintain it beyond 10 seconds, okay, you might get a transient ischemic attack in your clinic itself. Okay, so don't take risk in such situations. Okay, BPPV can be mechanically treated easily. Okay, you can have a please maneuver, or you have cannula 3 position maneuver. Okay, so a lot of what is called as the procedures to rotate the head and also the body, and then maintaining it. So that could be the better ones. Whereas VBI, you have to be very, very gentle. You cannot mechanically treat it. Okay, if you are treating it, you have to mobilize the lower cervical spine maximally. Okay, with the least provocation of symptoms. Okay, so VBI, if there is a compression vertebral artery, you should see what is the compression. Okay, that compression has to be removed. That's important. It might be osteophytes. Then osteophytes removal, it's very tough. Okay, so you cannot go ahead with that. So remember, the scope of a physical therapist treating a vertebrobasilar insufficiency is very less. Okay, whereas BPPV, it is more. Okay, and you might advise the patient to take good amount of water. Okay, avoid the extension or the extension rotation positions in standing or sitting. Okay, and non-specifically you want to treat, you can give them this what is called as visual vestibular habituation exercises. It will help both the patients. Okay, one directly it helps, other one indirectly through compensatory mechanisms. So either way you can treat. Okay, technically. But if you want to identify, neurologist will be the best person to coordinate with you if there is a VBI, okay, vertebrobasilar insufficiency. But if there is BPPV, the otorhinolaryngologist, otherwise called as the ENT physician, who has to be in close communication, okay, for the betterment of the patient. Okay, if it is BPPV. Cervicogenic vertigo, you don't need a big deal at all. You just treat the cervical spine, the vertigo disappears. Okay, you mobilize the spine, you give myofascial release, you give all the manual techniques for the neck, the vertigo is going to disappear. Okay, and so even the visual vertigo, the people, they might have problems in the vision. Okay, they might have problems in accommodation, or they might have problems in the color differentiations. Okay, so if you get their eyes checked, their vertigo is going to get definitely much reduced. Okay. Shoulder pain, vertigo. So we got 5, 6. 1, 2, 3, 4, 5, 6. 6 questions. Okay. So far. The benefit of going live like this, okay, people who cannot attend live also can see it later. Okay, so it's not a big situation like Zoom where you miss the session, it's missed forever. Okay, even Zoom sessions of AOMPT also, all the videos are available for purchase, so that people can take it for later reference. Those who attended live also can purchase those videos for recollecting, for improving their understanding. Those who missed the sessions, those who are occupied and they were busy with other work, can also get access to these videos so that they can learn at their leisure time. Okay, the best part of this videos, okay, I've also announced the set of videos for shoulder, 50 videos, and 30 videos for the elbow, which includes anatomy videos, biomechanics videos, physical examination videos, and also the differential diagnosis videos, manual therapy, which includes Syriacs, which includes Maitland, which includes what is called as miscellaneous techniques like ortho, myo, neuro, manual therapy, cupping, okay, and also even you have for kinesotaping and rigid taping, okay. So everyone who is going to purchase these videos are going to get the 8 certificates for elbow and 9 certificates for the shoulder, so depending upon the distribution of the hours for each topic. And these videos are lifetime access, okay. They are all direct, either recorded from my own workshops or in my classes which I take for the undergraduate Bachelor of Physiotherapy, okay. It's part of routine teaching, okay, as a full-time teaching faculty where I have taught in different institutions. So those recordings, okay. So you can imagine that this is the level of education which I am envisioning that our future students should have, okay. In fact, the present student is the future physical therapist, okay. So I teach the same what I teach in the workshops in the classroom also, okay. I enjoy doing that, okay. That is when the BPT will become much more stronger, and our physical therapist will be more equipped as first contact practitioners. Whether government gives autonomy or not, okay, patients will give that, okay. They will say that, doctor, you examine, okay, you give treatment. If I am not improving, then I will go to the other doctor, otherwise no problem, okay. So the patients are giving confidence to physical therapist, okay. They know that physical therapist cannot harm unless they are hyping up physios. What is that hyping up? They get trained on one technique and then next day they put, I am a certified technician, okay. So those kind of physios will be experimenting that technique on the patient and patient will worsen, okay. But if you are putting in terms of physical therapist, I am a physical therapist, okay, trained in these techniques, that's okay. But if you are putting certified, muscle energy technique practitioner, certified McKenzie instructor or practitioners, these all, you get an obligation that you have to keep using that technique, okay, for all patients. So patients become being experimented, okay. So remember that patients will also know that shortly that these are all narrowing the practice, okay. It's not developing an expertise, okay. Remember the DM, MD and MBBS, okay, what has happened? We should learn from that. MCH, MS and MBBS, the surgery line, okay. A person who does general surgery does the neurosurgery, super specialization, but they forgot the general surgery. They are not able to answer a patient who is having abdominal pain, okay. Directly they are referring to the general surgeon, okay. So this should not happen in physiotherapy, okay. If you are specializing in neuro, does not mean that ortho, whatever patient comes, you keep sending them. I know therapists don't send because they want all the patients, okay, but you should do justice, okay. You should actually give the best possible treatment that is possible, okay. And if your facility is not helping that, or you find the disease is out of your scope, you should refer to your own colleague, okay. Tomorrow you will get a patient from them also. So be open to see that patient must improve. Don't think that I have to improve this patient, no, okay. So even if you don't worsen and you give them the best direction also, it's much more than fine, okay. We don't have any questions. Okay. There are around 75 participants whom I said, okay, and we have 13, and I think of the 13 also, it looks like 10 of you have registered for this package, okay. Other 3 I am not able to identify, Okay. Okay. 4, 8, 9. Whenever for any palpation I am telling you that you mark it. Okay. Why I tell it is because it has to be visible. It's visible to your eye. Okay. If you cannot mark, it should be visible to your hand. Okay. That is the rule of palpation. Where are you marking everywhere? Okay. This is a very kindergarten question. Okay. Don't complicate. Again I am telling you. Your fingertip you can palpate the landmarks. You keep the distance. You don't need an inch tape. Okay. If I tell that you have to measure the distance, keep one hand on C7, another hand on the, for example, T1, and then superior angle of the scapula. You keep the fingers, and you have to measure the distance using inch tape. If I am telling, I don't have an inch tape, so what I should do? Come on, open your eyes. Huh? You don't know that this much distance means it should be 8 centimeters. This has to come. If you are a physical therapist, you don't need any tools at all. Okay? So remember that. Why marking is only because students who are watching, okay, they should get the idea that bony prominence is there. Otherwise, they will be thinking something else, okay, in some other world. Okay? So we mark that. Marking is for the first phase of learning. You don't have to keep on marking everywhere. Okay? It is to improve the accuracy. If your accuracy is better, by visually observing you do it. Why you need a goniometer? Range of motion assessment, why do you need goniometer? Visual observation you can be improved if you are regularly observing. So it's your skill is always your skill. Okay? If you don't use that, then what to do? Your hand is the one which is most important. Don't think about I am telling that take the pen and then write. You are asking me if I don't have the pen or I cannot write, then what to do? Not write, you speak. Simple. Think simple. Okay? So that is how you actually come to a better solution for patients. Otherwise you will be nowhere. Okay? Don't try to take the textbook totally into the practice. Okay? Neither teaching videos are make you to understand. Don't think that the same thing you will be doing on the patient. Okay? You have to do a different one, which is to do with positions, different positions. You will do the special test of standing first. Next you will do the special test of sitting. Next you will do the special test of lying down. Okay? But in teaching one, it will come special test for tendinitis, special test for impingement, special test for frozen shoulder, like that, for disease wise. That does not mean that we have to do all these special tests on everybody. Okay? We should see that from the history itself, this patient is frozen shoulder. Okay, these are all tests. Now patient is sitting, so I will do these tests. Okay? If the patient is comfortable to stand, definitely I will do the test in standing. Okay? Otherwise, if patient is lying down, I will do the test in lying down. So I have to do this. This if I don't do, I am not a clinician at all. Okay? So don't go by the information like a robot. Okay? You are the scientist. Okay? So don't think that the scientist has created a robot, so we have to use the same robot. No. Okay? I am strongly against that. In all my videos, I have always mentioned that you have to be more dynamic. Okay? You have to apply it. Understood? So don't be stuck. Okay? Don't look at the obstacles. Look at the way. Okay? And don't be thinking like this is not there, what I will do. You can do everything. Okay? Anything you can do. You don't need a special test to actually diagnose. Okay? If you can visually observe properly, tactile wise you can palpate properly, and biomechanically you can test the structures properly, you don't need special tests. Okay? Because these special tests are also based on the same principles. Okay? But they are not interlinking observation to palpation to movement testing. Okay? They are basically movement or contractions. Special test means. Okay? So remember that. So when you do palpation, when you do relate it with observation, and also with history, then the picture will be perfectly clear for any situation. And you have to look at the solution to get it done. If you don't touch the bone, even then you know that bone is there. Okay. If the patient cannot remove the clothes, your visual skill should be improved so that you can observe through the clothing. Okay. With the clothing also you should be able to see the bony prominence. Okay. How will you improve that? As you keep observing only, you will improve. Okay. You cannot have radiological vision. Okay. Or keep doing 3D spine align for everybody. Okay. So remember that improve the skill, that is most important here. If you don't want to use a pressure algometer, okay, which you are checking for tenderness, pressure pain thresholds, okay, that means your finger has to be sensitive. Simple. Okay, you don't have the device, then what to do? Pressure biofeedback is there to assess the deep cervical short flexors endurance. So if the pressure biofeedback I am not having that, so what to do means manual palpation is there. Okay, so for everything there is a manual one. Problem with manual is between one therapist and another therapist it is not reliable. Okay, why it is not reliable? Unfortunately, single person is not teaching everybody. Okay, today I am teaching all of you, tomorrow someone else will be teaching. Okay, day after another person is teaching somewhere else. Okay, all three our descriptions will be different. Okay, so that's why the differences come in reality also. Understood? The reliability, it's different, unfortunately, because we don't have a single globally known expert, and that single expert is teaching the whole world. Okay, if that is the case, then only reliability will be there. Okay, otherwise every technique will not be reliable. Even surgical approach also, or even medications also, different medicines have different effects. All are same chemical property. Okay, a simple paracetamol, you know that there are 18 paracetamol tablets that are commercially available. Only specific companies the paracetamol will respond to you. Why? Okay, it is the match between the patient's body, the homeostasis, with the composition of the chemicals what is given. So the same, your reasoning and your patient's dysfunction should match. Then you are going to get the best picture. Okay, you give the paracetamol directly in the mouth, or you dissolve it and then make the patient to drink, or give a paracetamol injection, for example. Okay, why do you do that? Because somebody cannot take it through the mouth, so you give it as injection, especially for syrups you give for children. Okay, so these are all different mode of application, because somehow we have to get it into the body. Same way, procedure is not possible, another procedure you have to do. Okay, if you don't mark it, improve your skill of palpation. Okay, so that's the basic perspective of looking at the way rather than looking at the obstacles. Okay, we have a query which is a very direct query: thoracic outlet syndrome, how to diagnose. Okay, you know that there are diagnostic tests for thoracic outlet syndrome. Okay, you have the AdSense test, you have the elevated arm stress test. Okay, definitely you can do the diagnosis. In the AdSense test there are various components. Shoulder girdle depression, for example, will test the costoclavicular syndrome. Shoulder extension will check the pectoralis minor syndrome. Okay, deep inhalation will check the scalenus anterior syndrome, and neck rotation to opposite side, which is in AdSense, and neck rotation to the same side, which is in modified AdSense, will check the cervical rib syndrome. Okay, the 4 subtypes of thoracic outlet syndrome you can easily check. Okay, and arterial versus venous, whether it is the subclavian artery or the brachial at the pectoralis minor versus the vein compressions. Okay, that is upper limb, you know the vascular symptoms, arterial symptoms what will be there, and venous symptoms what will be there. Okay, aggravated with elevation, cold extremities, relieved by heat, warm water, okay, hot room temperatures, must be arterial. Okay, aggravated by dependent positions, okay, warm or bluish extremities, and heavy sensations of the extremity. Upper limb is very heavy, the patient tells, okay, and relieved with cold and relieved with activity, okay. Muscle contractions relieves the symptoms, that is veins. Arterial symptoms will aggravate with muscle contraction because there is no blood supply to the working muscles. Venous symptoms will relieve with muscle contraction because it's the pumping, muscles push the blood back. So these are again the basic things. I think you should get a video access, okay. If you don't watch the videos of AOMPT, you may not understand, okay. This participant has enrolled specifically for this interactive session. He has not got access to the videos, okay. So remember that whether you are going to release the scalenus anterior, okay, or you are going to mobilize the clavicle, okay, or release the pectoralis minor, depends upon the type of the thoracic outlet syndrome. Neural, definitely neural symptoms will be there even if it is arterial or it is venous. So you have to do the neurodynamic testing in order to differentiate between different parts or the divisions of the brachial plexus, okay. So most of the times some patients have relief with shoulder elevation because it is costoclavicular syndrome. Some patients have relief with retraction, okay, when they are pectoralis minor syndromes, okay, and patients have relief with what is called as breathing retraining, breathing pattern disorders. They have scalenus anterior hypertrophy creating a thoracic outlet. So you might find a trigger point in the diaphragm and you are releasing it, and then you are making them to restore the breathing pattern, the depth, the scalenus anterior. Then after that myofascial release will be much better. These patients will improve, okay, secondary, because breathing pattern disorders. That's why scalene was active. Cervical rib, whatever you do, okay, it's only the maintenance. You only taking care of the complication should not come, okay. So surgical also it's very poor, okay, if you are going to indicate the patient for a surgery, okay. So better treat them conservatively as much as possible, okay. What they do in surgery is just release the fibrous bands because there are additional attachments of the scalenes to the cervical rib will be there, okay. So most of us might have a cervical rib which is only the elongated C7, the transverse process. Thoracic outlet syndrome is there, does not mean X-ray showing a lengthened C7 does not mean cervical rib syndrome, okay. It might be costoclavicular only, or it may be pectoralis minor syndrome only. In X-ray it is showing a cervical rib, okay. So don't think that the findings are that means that it is causing each other, okay. It's cervical rib syndrome. It should be a diagnosis of exclusion after scalenus anterior is ruled out, costoclavicular is ruled out, and pectoralis minor is ruled out, okay. And you find that neck rotations are predominantly causing the symptoms, okay. So arterial versus venous, okay. So that's the focus. Neural, it's going to be the similar protocol as radiculopathy or cervicobrachial pain syndromes. Same way you will assess the ULNT 1, 2, 3, 4. Okay. Tenel sign, of course, percussion on the nerve. It's again part of the neuro manual therapy. Okay. We are still in the neck. Little bit we went to the shoulder. I don't think we have come to the elbow or the wrist and hand, okay. We have another 37 minutes, okay, maximum, and if there are less questions we can wind up early, okay, because the participants who are here, they should feel that they were part of this interaction and they learned something, okay. That's most important. Okay. Because this is a forum for mutual expression. Okay, you ask your doubts, I explain my understanding of the situation. Okay, I am not giving you answers. Okay, I am just giving my perspective. Okay, what I understood, and listening to that you should get a okay, there is a path of thinking. Okay, right. Okay, you should find your own solution. Okay, so that should be the point of this discussion. Elbow, we have collateral ligaments, we have pulled elbow, we have student's elbow, which is olecranon bursitis, we have tennis elbow and golfer's elbow. Okay, we have the supinator syndrome, we have the pronator teres syndrome, we have the cubital tunnel syndrome, and okay, we also have the impingement syndromes around the elbow. Whereas wrist and hand, it's predominantly the ligament and the tendinitis, okay, which is to do with either collateral ligaments of the wrist or the dorsal versus volar carpal ligamentous instabilities. And then you come to tendinitis in terms of de Quervain's disease. Okay, in the forearm, the intersection syndrome. Okay, and next coming to other soft tissue injuries like trigger finger, trigger thumb, de Quervain's, the Dupuytren's contracture for the palmar aponeurosis, and you also have the deformities of the fingers, which might be resulted from the median nerve, ulnar nerve, or the radial. Radial, of course, creates only the wrist drop, whereas ulnar nerve injury creates the claw hand, and median nerve creates the median claw hand or the ape thumb deformities. Okay. Diseases like rheumatoid arthritis can create various deformities in the fingers, bottom-hair, swan neck, intrinsic plus, and ulnar drift. Okay. So you have the mallet finger, which is avulsion of the extensor digitorum tendon, whereas the swan neck deformity is from the metacarpophalangeal joint deformity caused due to rheumatoid arthritis. Okay. You might have abnormally palpable enlarged nodes at the proximal interphalangeal and the distal interphalangeal, called as the Heberden's nodes and the Bouchard's nodes, which are characteristic of primary osteoarthritis. Okay. And you also have the hand being a major area of examination in autonomic dysfunctions. Okay. To observe for nail bed atrophy, to observe for skin changes, trophic changes, and you also see the central pain mechanisms being more whenever there is a disorder of the hand. Okay. Median nerve carries the autonomic fibers to the upper limb, so you have entrapment of the median nerve, you are likely to get autonomic dysfunction. Okay, most commonly, compared to the ulnar or the radial. Ulnar, for example, at the pisiform we have the hypothenar hammer syndrome. Okay, and also the triangular fibrocartilaginous injury, the ulnar side of the wrist. Okay, ulno-triquetral joint fibrocartilage. So you have various situations. Okay, you can have trigger points. Mostly trigger points come in the intrinsic muscles. Okay, very rarely it comes in the adductor pollicis. Okay, or it has to come in the opponent's pollicis. Okay, otherwise the other intrinsic muscles, all of them are stabilizers. Okay, lumbrical trigger points very rare. Okay, and also what is called as the tenosynovitis or the tenovaginitis of the long finger flexors. Okay, synovial sheaths, which might accompany the trigger finger. Okay, or it may be independent one. Okay. Of course, other conditions like leprosy can cause autonomic disturbances, and also ulnar nerve infections, which can lead to hand deformities like claw hand together with the or triple nerve palsy, where there is a wrist drop with a total claw hand and an ape thumb. Okay, so all are present together. So that's about the hand. Okay. Even peripheral vascular disease, for example, arterial or it is venous, can create symptoms in the shoulder, elbow, wrist and hand. Okay, all segments. Okay. One of my patient is having elbow pain. While playing, suddenly it will come. It seems later, after 1 or 2 hours, it will come down. But thing is, every day she is not getting. What could be the reason? That is why arthro-myo-neuro-manual therapy. Okay. So these are things where the unanswered situations where a combination of structures. Okay, it's not that if it's only muscle problem, every time whenever you activate the muscle, the symptom will come. Okay. If it is only a joint problem, every time you compress the joint, every time you stretch the joint, the symptoms will come. Okay. Nerve, if every posture that is actually vascular challenge to the nerve in terms of compression of the nerve or tension of the nerve will lead to the symptoms. Okay, individually. But if it is combination, 3 people are working, so you don't know who is actually causing whom. Okay, so A, B, C are there. So if it is A, M, N, articular, myofascial and neural. Okay, symptom comes when all 3 are working. Okay, individually when you are actually checking, nothing will be there. Okay, and the next thing, A, M, N, A is working 60%. M is working 30%, N is working 10%, articular, myofascial, neural. Then that symptom might come. Okay, I am telling you a ratio, 60, 30, 10, the proportion. Otherwise, if A is working 40 and M is working 50 and N is working 10, symptom may not come. Although all 3 are working in the same activity, it will not come. So that's the picture there. Okay. So when you are actually seeing a combination of stress, multi-structural perspective, okay, so it's a combined stress, it's a functional activity, it's an aggravated demand, okay. So in that scenario, unless the particular proportion of stress is not there for the individual components, articular, myofascial and neural, the symptom reproduction will not come. Okay. Relief, automatically the functional activity is stopped, the person will be better, and they won't actually remember what exactly that particular during that when the symptom comes. Okay, unless they have a very good self-awareness. Okay, so you got a picture now. A patient who is having an excellent self-awareness will tell you that I am playing tennis, so especially when I am going reaching behind and I am overhead reach. Okay, when somebody gives a high return, okay, when I am doing that I am getting my pain in the shoulder, or example elbow. So you need to know that particular mechanism. You can try to explore further. In that position you can keep the patient and then check the articular by producing compressions. You can check the muscles by giving contractions, okay, or check the nerve by moving the joints like neck or the knee, okay, when the arm is in a fixed position, symptom position. If the patient is not having a self-awareness and they cannot tell that, it usually happens. Competitive game, you don't realize. Okay, at the end of the game only it comes. It does not come during the game. Then it's a overuse injury. Okay, so this overuse injury is there every time. It is not bothered the patient much. Okay, and because after the game the pain comes, they are concerned. Okay, tomorrow will I be able to play? Okay, so they come to you. So that is the second part of the story. Okay, if it comes during the game, they will definitely tell particular position I was getting the symptom. Okay, however after that I was very careful in my play and I didn't get any pain. Okay, it didn't aggravate during the game, but after the game 2-3 hours then it went. Next day when I played I did not get the pain. Why? Because the same proportion of the 3 components were not matching. Whenever it matches, it will come. Okay, so that's why AOMPT specifically developed the approach arthro-myo-neuro-manual therapy. Okay, explore and see. If you get the video, the general principles and the elbow AM and MT, definitely either of the 6 subgroups the patient will be presenting. Okay, and then you can treat them in combinations. In the combined position, you will get the reproduction of symptoms. It might be a backhand position, for example. Nothing is there. Patient will tell no pain. But in the backhand position, you give a compression of the radius. Okay, so that means humeroradial compression, joint, articular, and then you give resisted contraction to the supination. Okay, or the resisted contraction for the elbow flexion in the mid prone. Okay, so you are actually activating the supinator. Okay, and then together you keep the finger inside, the thumb inside the fingers. Okay, keep it in radial nerve position with ulnar deviation. Okay, and then bend the neck to the opposite side. Okay, so you are given a radial compression, you are given a supinator contraction muscle, and then you are given the neural position, radial nerve. This is all for the lateral side of the elbow, which you will know from the history. When you do this in combination, the patient will tell you, yeah, that's slight pain I got. Okay, that's like you are like a private detective. Okay, you have found that problem, so they will know that yes, you are going to treat that. The testing position is going to be the same for the treatment also. Okay, you are going to give mobilization of the radius in the combined position with the contraction. You are going to mobilize the radius. Okay, or in the same position, compression is given, neural mobilization is done, radial nerve mobilization. Okay, or you are adding on in the same position, nerve is also maintained, joint also maintained, and you are giving a myofascial release to the trigger point. Okay, so you can treat articular, or you can treat myofascial, or you can treat neural with the other 2 components loaded. Okay, combined loading and then position, and you give a treatment. Okay, this Wednesday I am going to talk about the arthro-myo-neuro-manual therapy for foot and ankle. Okay, it's a great thing. I was telling you about the milestones this August. Okay, one of the milestone was we got our own AOMPT member who interviewed me first time, my first interview. Okay, on the social media, Instagram. Okay, Dr. Srinivas Nayak, and that was my first interview. Okay, after 20 years. Okay, so you can imagine Corona, and the most important point is after that, it is now officially in this lockdown especially. Okay, one physical therapist is organizing my webinar. Okay, this is first. Okay, so otherwise AOMPT has been organizing, it's my own. Okay, I was organizing my own webinars. Okay, this is the first that during this lockdown that another person is organizing my webinar. Okay, so this is a bigger milestone for me, and Dr. Sunil Bhatt is a great visionary. Okay, and as part of alumni of Manipal University. Okay, so he is also an alumni, I am also an alumni. Okay, I was also a faculty for 10 years at Manipal, so he has included so many people, and he has great regards for me right from beginning, I know, and I am happy just to associate it with him. And under his platform, Dr. Bhatt's physiotherapy education series, okay, he is organizing this arthro-myo-neuro-manual therapy, foot and ankle. Okay, 1 hour free webinar. So for those who want to learn the combined perspective, okay, AM and MT, the registered approach of the AOMPT. Okay, also those who got a better, deeper insight you want, you can get access to the 10 webinar videos, and also the 13 practical demonstration videos on AM and MT. So it will give you a better insight. Okay, recently concluded package before the osteopathy techniques. Okay, we got the AM and MT 10 webinars, 10 days package. Okay, so you can get those videos with certificates, so you can get a better perspective. Okay, especially multi-structural perspective. Okay. Do we have any more questions? Yeah, some of you might be, thinking that I am wearing a very, very bright, colorful shirt. Okay. This was actually purchased in Goa. Okay. And in February. Okay. So sometimes we hardly think, that we buy a shirt, okay, in Goa, okay. Next time we keep waiting, like whenever we go to the beach, we'll wear this shirt, okay. So it's like fun, party, okay, everything. But the truth is, as much you enjoyed there, okay, so much you have enjoyed, so much of your positive energy is there in the shirt. You wear the shirt even when you are in a room during lockdown also, okay, you'll get the feel that you are at Goa, okay. So I wanted to test that, okay. So that's the background behind me wearing this bright colored shirt rather than the usual whatever formals, the full sleeve, which I keep wearing, okay, which most of you might have been seeing again and again in that same shirts, okay. So yes, most important thing, for example, even in your clinic, okay, make sure that it's more bright, more attractive, okay. It's good for positive energy, okay. Having an aquarium, having a fountain, okay, anything that is water is flowing, or grow the plants, okay, keep the pots, plants everywhere, so that it symbolizes the growth, the development, okay, and it keeps the environment natural, okay, purifies the air and also makes it colorful, okay. So put some education posters, okay, which will be of information for the patients. So all these are very, very important, okay. You might think that I am good at my hands, okay, I can show the results, however the clinic is not a problem. No, okay. So if below your consultation table, for example, in the side you have kept all the books and papers arranged on the floor, I don't think so that's the best environment which you are showcasing to your patients, okay. Sometimes you might find some patients are bargaining with you, okay. They might they might negotiate for the consultation fee. They will tell that they will ask the clinician that how much is the fee, sir, like that, okay. Immediately you should tell, my secretary will tell you, okay, or the receptionist will tell you, like that. You should not tell the fee, okay. If you are telling the fee, that means you get victimized, that they will go for negotiation with you, okay. You become like a distributor or a shopkeeper, okay, and they become a customer and consumer, okay. So it's not that like a human being treating another human being, okay. You have to maintain this in clinical practice. If you don't have a subordinate staff and you are the in charge of the clinic and you are collecting the money, means God save you, okay. You can't be like not trusting anybody, okay. You have to keep a staff, they should collect. You can watch it in the system, the CCTV, okay, but make sure that you are not going to collect the fee directly from the patient, okay. Even those who are doing house visits also, don't collect the money directly, not just because of this lockdown, avoiding hard cash. Every time an online transfer is always good, okay. So they pay prompt and they should pay advance, okay. It's not like they pay after the treatment, okay. So it should be fixed that the time 1 hour, okay, if your consultation charges or treatment charges means, okay. Be very, very professional in your clinical practice. Why I am telling you this specifically is because it's another concern why patients do not respect physical therapists. Okay, it's because many of these little things we don't maintain that. Of course, other than the social media where we are appreciating each other or not, we are cursing each other, we are attacking each other, okay, we are fighting with each other, will also give a negative image, okay, absolutely, to your patients. So make sure that we build a positive image. We are a positive profession, okay, so we can create huge wonders, and we don't need any expensive equipments or even a setting, okay. You can treat a patient right in the middle of the road, okay, or even in a village where you are going for an outreach or a community visit, you can treat them anywhere, okay. So physical therapists have that thing that it is just in our own body that we can treat, and in the patient's body what is there you should find it, okay. Most importantly, these two parts which are very important to improve your skills, okay, and definitely you will be the best brand ambassador to showcase that physical therapy is the best profession, okay. Students, of course, they have their own priorities and preferences, okay. So it's the role of the teachers to actually guide them, okay, inspire them, either by treating patients or by the involvement in their teaching, okay. The more deeper you involve in teaching to provide the knowledge to the students will feel that sincerity, okay. They might make fun of you in the beginning, they might just ignore you in the beginning, but later they will try to understand that the same information they are paying so much fee and they are not learning anything, okay. So they will come back to you to learn, okay. That's always happens. And keep making sure that one thing is, the sincerity, it's not just for others, okay. Whether your subordinate is there or not there, your treatment will be the same. Your superior is there or not there, your treatment will be the same, okay. How you handle the patient or how you work in a college, everything. That is called as integrity, okay. So that if you maintain, the one supreme power knows that you have done the work, okay, you are doing it really truthful, okay, and the reward may not come immediately, okay, it might be delayed, nobody knows, but when it comes really very big, okay. So trust me for that, okay. So just be very integrity, okay, full of integrity, okay. And be responsible that if a patient is not improving means my skill I have to improve, okay. If I am not able to diagnose, don't think that patient is confusing, okay. They will be confused, man. They are having a problem, they are supposed to be confused, okay. Don't expect them to be clear. But if you are a proper one who can give them the best direction for solution, you should be upgraded, okay. So that's where you can do the best for others, when you are the best, okay. If you are not a diamond, you can't show the glitter or the light, okay, or the strength of the crystal, okay. If you are an original diamond, you are the strongest, but if you are a duplicate one, it's absolutely worth for nothing, okay. So think of that, okay. It will glitter, it might shine, but it may not be the strongest and it won't be of that value, okay. So updating is just by knowing what are the developments, okay. That is staying updated. Upgrading is actually your own self-reflection, that am I getting better or not, okay. So that I have to make it better. The Senthil who was yesterday versus today, okay, that is upgradation, okay. So then you are on the right track. And the same way, for everything, make sure that you are taking onus and the responsibility that you have to improve your skill, but you are treating the patient, okay. But the result, of course, definitely will be good as much as you are sincere enough to actually apply what you have actually upgraded. Okay, if you are sincere, then the Supreme Power knows that, and automatically through your hand no patient will worsen. Okay, even if you don't touch the patient and treat also, when you talk and just listen to the patient will feel that, oh yeah, after talking to him I am clear what I should do. Okay, so that happiness will come, they'll be able to take a better solution. Okay, so that's the important closing words. So we are ready to wind off today's session. Okay, if everyone is happy, okay, so we can close this session now, and wish you very good luck. Keep in touch. We'll shortly come up with the lower quadrant special test and differential diagnosis. Lower quadrant includes the lumbar spine, pelvis, hip, knee, ankle. Okay, the 5 segments. So that also will come. I'll update you whether it will be on the Facebook or it's on Instagram. Okay, but even then, make sure that those who are enrolled are watching the videos and utilizing the maximum information that is there, and integrate it with the interactive session here on Facebook. Okay, so good luck to you all. See you. Enjoy August, and we have got the World Physiotherapy Week coming up in September. Okay, AOMPT has not planned anything much bigger, so much bigger, anything like that, but only the sports physiotherapy, the webinar package will come. Okay, that's important. Clear? So stay tuned, stay connected, and stay positive. Okay, not corona positive, it should be positive during the corona lockdown. Okay, so see you all. Bye bye.